and there's too much acid splashing up against the esophagus can lead into a metaplasia. And they take that very seriously because once that adaptation occurs, you don't know if that's going to lead into a cancer later on. Okay. All right. So now the very last one, I think of the dysplasias, or but of adaptations, dysplasia. Dysplasia is what we call a disordered appearance. So as you can see on your image sheet, you have on one side squamous cells. Okay, those are actually squamous cells. And to give you the exact issue there, that is a picture of cervical dysplasia. That is a picture of cervical dysplasia. So the one side is the normal cervix with the normal squamous cells that are real nice and big. And then when you look at the other side that's like really dark, and you see all the nuclei just kind of clustered together, that's the dysplasia. When you see dysplasia, the issue is this: you can't tell the size, the shape, or anything. You look at it and you can't tell what it is, okay? You can see the nuclei, and when you see nuclei just kind of clustered together, that's kind of a telltale sign that this may be cancerous or precancerous. So understand that cells should never be all clustered on top of each other like that, okay? And I think you guys probably know that even from anatomy. So, what I want to say here. Now, again, this is preneoplastic / or what also known as precancerous, which means, just to give you an example, years ago when I was in college, I used to work in a GYN office, and some small offices, I don't know if they still do this, was a long time ago, they actually have a lab right in the office. Okay, and believe it or not, the nurses were the ones that prepped the slides, and they actually were the ones that looked and found the dysplasias. So even though I think nowadays everything just kind of goes out to the lab, but please understand, in this situation with cervical dysplasia, it had to be removed. These patients would get, I don't know if they still do these procedures, like a cryo, where they would kind of freeze off the epithelium, or a loop, where they would scrape off the epithelium. So you have to remove that tissue. And the philosophy behind this is this: if you remove that tissue, what you want to see is if that tissue is going to grow back and regenerate, hopefully normal, or if it grows back, it may be to dysplasia again, or maybe worse, and or a higher degree of dysplasia, I should say. And then if that happens, then they'll start staging the patient, okay, for cancer. So just understand that dysplasia has to be removed. Okay, now is it reversible? In because your book, and this is what one of the students had emailed the question to me last term, because the book states that it's reversible. It's reversible clinically, but it's not reversible, I don't want you to think, just by itself. Okay, so you have to remove that tissue. Can it reverse back? Yes, but you have to remove that tissue, clean the slate, so it can grow back normal. Okay, and that. Okay. So the next topic that we have to cover, necrosis. When you think of necrosis, what do you think of? Death. Okay. Death of the tissue. Tissue's dead. And so yes, this is exactly what happens. The cell dies. And if the cell dies, what happens? The cell actually will burst. And the contents of the cell spill out into the neighboring tissue space. Which is why when you ever look at necrotic tissue or hear about it, it's usually discolored, okay, so maybe darker. The tissue also changes in texture. It may be hard, may be soft or brittle. Even necrotic tissue can smell. Okay, I remember one time I was in the hospital volunteering, and nurse ran out of the OR. What happened was they were operating on a patient that had cancer. And sometimes when patients have cancer, some of those tumors can actually become very necrotic. And from what I understand, when they open up the patient, it smelled very bad. So she just been taken and she had to leave. So just keep in mind, necrotic tissue can be very, can smell bad because obviously of the tissue death. So again, what happens is the cell rupture spills the contents of the cell in the tissue space, which makes this whole thing, okay, a big mess. Now, normal cell, which we know what it looks like. Reversible cell injury, we already discussed. This is where the water comes in, so we already know that. Now, down here shows you a picture of irreversible cell injury. Okay, so let me just explain that. So, the major thing here with irreversible cell injury is just knowing the term lysis. Okay, L-Y-S-I-S, lysis. Meaning that the cell membrane will lyse. Not only does the cell membrane lyse, but also the organelles will lyse. Okay, so once now this cell is torn apart, there's no going back. Okay, and that's it. And so that's exactly what happens. Now, we do have 4 different types of tissue necrosis. Okay, let me tell you the terms so you won't get confused, and we're going to go over this again. We're going to go over necrosis and then gangrene. And they're pretty much the same, but not the same. Okay, so when you use the term necrosis, that's explaining the tissue, so like the pathogenesis of what's occurring. When you use the term gangrene, that's saying the body part. Okay, so the foot is gangrenous, or the hand, or whatever. But the necrosis is how we explain the tissue, almost like explaining the pathogenesis. Okay, so we do have different types. So we have coagulant necrosis, which most of the times is due to a lack of blood supply. Liquefactive necrosis, and I'll go over the pictures after this in a second. Liquefactive necrosis is when we have a liquefaction of cells. So I know that sounds weird, but the cells just actually start to liquefy, and even the tissue turns to liquid. Fat necrosis. This is where we have death of adipose tissue. So just imagine adipose cells or fat cells all bursting at one time. What's going to happen is there's going to be an accumulation of fat, okay, in that particular area. Caseous necrosis. Caseous necrosis is actually secondary to TB, so sometimes with patients that do have TB, if it's gone on too far, this can now lead to a lack of blood supply to the lung and lead to this type of necrosis, which looks different. Okay, and I'll show you in a second. So here are the pictures. To kind of help you with this, and I think this will make sense, when you have a lack of blood supply to an area, that tissue most likely will become darker, okay? In most common extremities, okay? Extremities are the ones that usually get dark. When you have internal organs usually undergo a different type of necrosis, okay? So I'll go over that in a second. So here we have the toes, and so you do have in your image sheet, I think it's out of order, but you'll find it. So with the feet, we do have the coagulant necrosis. And then for the brain, as you can see at the top, this little bubble here, it almost looks like someone poured acid on it, just bubbled up. That is the liquefactive necrosis, so the whole tissue just turned to liquid. And then this is fat necrosis, and I want to say that this is the pancreas, if I'm not mistaken. And they say that this is secondary, or I should say common as pancreatitis. And then this one here is the caseous necrosis. Okay, and this area is the necrosis. Now, believe it or not, if you were to touch that, okay, not that you want to touch it, but if you were to touch it, that is actually very soft and it would like crumble. So I don't want you to think that it's hard, okay? Most of the hardened appearances are more like on the outside, like epithelial type. Inside type of necrosis will be a little softer. Okay, so what is the issue here as far as the cell membrane is concerned? They feel that calcium is the culprit. Okay, so calcium, if you have excess calcium that enters inside the cell or is produced too much inside the cell, they believe that calcium can lead to all of this membrane damage, okay, as well as damage to the nucleus. Okay. So you can go over that chart. Now, gangrene. As I told you earlier, gangrene is the body part, okay, and so this is how it works. So dry gangrene is a form of coagulant necrosis, okay, which is why in your image sheet I have a picture of dry gangrene, which is another picture of the foot. Okay, so the same thing. gangrene is a form of liquefactive necrosis, and in your image sheet, I have a picture of the intestines. It is very dark, it's black, as you can see, probably because of a lack of blood supply too. So let's say, for example, that person maybe had like twisting of the bowel or something where the intestines twisted, or some sort of blockage where there was not enough blood supply getting into the intestines, which made it discolored. On top of that, liquefactive. Okay, so there's excess liquid there. And then the last one we have is gas gangrene. This is from Clostridium bacterial infection, which I'm sure you guys may have gone over in micro, maybe. And so this type of bacteria, believe it or not, can actually infiltrate the muscle tissue, and it can cause damage to the muscle tissue, and it can even make these like nasty gas bubbles, okay, within the muscle tissue, which you see there on your picture. And that's an extreme case. I would imagine that could not be taken care of with antibiotics at that point. So
something like this with that patient then?
That might need amputation. I would assume that's an extreme, and I don't know how fast that develops, to be honest. But yeah, I would say at least amputation. I don't know what's going on with the rest of that person. Yes.
What type of necrosis was gangrene again?
This one is, they put this kind of in a class by itself, but I want to say that might be more of maybe liquefactive. I would say more synonymous with liquefactive. Only because it's actually destroying the muscle tissue. So even though it like makes these gas bubbles, but it kind of rips it apart. It destroys the muscle tissue. Okay. Yes.
Do they all develop at a certain rate? Like, does the wet gangrene develop faster than the gas, or it's just?
It depends. It depends on the progression of the disease and how long, the severity of lack of blood supply, or it depends. Each case is different. But I will say this, because someone had a question yesterday regarding this. There would be signs and symptoms in the patient from, say, if there was an obstruction or lack of blood supply, from like numbness and tingling and coldness or things like that. That would warrant you, obviously, to look to see if it's gangrenous. Okay. So sometimes when it gets to a real extreme gangrenous point, do they have any type of feeling? No. But however, you'll know prior to it. Okay, I think that was it. Okay. All right. Okay, we're doing okay on time. Do you guys need a little break, or you're okay? Okay. Let me do, let me start with chapter 7. Okay, I think we'll be okay. What I'm going to do, because like I said, I still want to try to get you guys out of here a little early. I'll sum up the treatment, okay, on one slide, but they have, I think the last few slides of this PowerPoint just goes into detail with cancer treatment, but I can sum it up, okay, so to save a little time. Okay, so this particular chapter focuses on cancer, okay, so we're just going to go kind of like a brief overview with understanding the difference between benign and malignant cancers, understanding a lot of risk factors, signs and symptoms of cancers, complications, and go over treatment. Okay, so we'll just introduce this because this particular chapter sets the stage for next week. Next week we're going to go into more detail with cancer, and we have an entire chapter on leukemias, okay, and lymphomas that we have to focus on. And we'll talk about cancer pretty much the rest of the term. Okay, so first thing we have here is neoplasia. Neo meaning new, plasia meaning growth. And in this situation, I think we all know that we're talking about not normal growth, but abnormal growth, okay? Just to kind of jump down right here, they say that cancer is what we call an altered gene expression. So some doctors believe that we all have a cancer cell inside of us. And if you want to look at it that way, yeah, that is kind of true. Because cancer develops just from an altered mitosis. And so it's just a matter of if it's going to develop into that cell, maybe, maybe not. And so the other thing here is that we will go into detail with describing the difference between benign and malignant. So when we hear benign, we know that that's the good sign, okay, because it's a little easier to cure, whereas a malignancy is the bad diagnosis because it's usually obviously complicated. So we'll go into those complications. Now, in your book, there are 3 tables that I do need you to know. So in your book with this chapter, there are 3 tables, table 7-1, 7-2, and 7-6. Okay, so when you go home to study, just make sure you go over those tables. Just kind of add that in. And so I'll explain. Don't be a teacher. Kill your voice. Okay. Table 7-1. This goes over the difference between benign and malignant tumors. So it just goes over the characteristics. 7-2, this table actually lists all the different names of the different cancers. Okay, so I don't want you to get too crazy with it and memorize each and every one. But however, I do just want you to take a look at the table. I'm going to go over with you in a little bit to show you what is called the nomenclature, how we name cancers. So you can look at any cancer name and you'll know exactly what it is, okay? But in that table, everything's listed here. Table 7-6 actually is a table of what we call tumor markers. And so what are tumor markers? Tumor markers are this. It can either be maybe an antigen, sometimes a hormone, maybe an enzyme. So it just depends on where, or I should say which organ the cancer, the primary cancer occurs in. It will always secrete a tumor marker that actually flows in the bloodstream. So say for example, if a person has prostate cancer, and then if it's malignant, it spreads, okay, and it spreads to the femur, and then it spreads to the thyroid, okay. What will happen is this, the body will never trick you into thinking which one's the primary cancer. So you will always release a hormone, or I should say a tumor marker, for the primary cancer. So just keep that in mind. And so for this table, I'm going to have you guys memorize the tumor markers for the top 4 cancers, okay, which are going to be breast, prostate, lung, and colorectal. Okay, so those are the top 4 cancers, and we'll go over that again. Okay. So, malignant tumors, yes, can kill if it's untreated. I think we know that. When a malignant tumor occurs, please understand that there's 2 ways that cancer spreads, through the blood and the lymphatic system. Okay, so that's how it spreads. They can be invasive, where they just kind of go to the neighboring tissues, or they can metastasize through the bloodstream or lymph to a whole different area. Okay, so it just depends on how aggressive it is. Now, there's something called tissue-specific differentiation. Okay, say that 4 times. Now, this means when patients have biopsies done, okay, so they want to check and see what's going on, a biopsy's performed. When they take that tissue to the lab, what they're looking for, the pathologists are looking to see, you know how we looked at the slide with the dysplasia? They're looking to see if that dysplasia is like to the 10th power, okay? So what happens is this, they look at the disorderly appearance of the cells, and they actually have a different grading system for it. And so when they look at this tissue, they'll be able to distinguish, okay, do these cells look kind of like the tissue type that it's coming from, or does it not? And so if it does not resemble the tissue type whatsoever, that's how they categorize it as a malignancy. Another thing with malignant tumors is that, unfortunately, they do have a lot of blood vessels surrounding them, okay? They have a very good, adequate amount of blood supply, which means just like anything else in the body, if you have a good blood supply, it's going to survive and grow. So when they have that blood supply, this is what makes those tumors grow. One thing that they try to do with, say, radiation therapy, we know that radiation therapy we hear is to try to shrink the tumor, but what the goal is to try to kill the blood vessels to try to shrink the tumor, okay? Because if you stop the blood supply, then hopefully that will stop, okay, the tumor from progressing. So that's that. Okay, we looked at that picture already. You have that. This is surface. Okay, so benign tumors. Benign tumors, they are not that dangerous. However, if a benign tumor is in a location that can cause issues, it should be removed and it can be complicated. So an example that I'll give you, my sister has a friend, she had a lymphoma on the posterior part of her shoulder. So lipomas, as you know, just little fatty tumors, okay, not a big to-do. Usually people don't like them for cosmetic reasons, but the doctors usually don't touch them because it's just a benign little fatty cyst. So in her situation, unfortunately, her lipoma actually became larger and it started to restrict her range of motion. And so then they had to remove it. So it just depends on the location. Benign tumors do not spread. And one of the reasons why they don't spread is because, number one, they do not have enough vasculature, okay, surrounding it. So they don't have a lot of blood vessels like malignant tumors. So they just pretty much stay their same size, okay? And the other reason why they don't spread is because they're encapsulated. So let me show you something else that'll help. So, when you have a benign tumor, and when we say encapsulated, let's say, for example, going back to the example of the lipoma, okay? So say someone has a lipoma, okay, on their hand or arm or whatever, and you're able to palpate it. If you feel this lipoma and it's nice and round, okay, and it's pretty much, how can I say, circular or well-defined, that's a good sign. So that means that that particular lipoma is well-defined, meaning that it's encapsulated, and that's a good sign. If you were to feel it, okay, and you can't figure out the shape or size or what's going on, and you can't quite, manage the edges or feel the edges, that's not a good sign. That means that this is not encapsulated, which means that this particular tumor, and the reason why I drew these jagged edges here is because now it means that this tumor is a little more fixated, okay, into the neighboring tissue, okay, which brings me to another characteristic. If you feel, and again, this is if you have palpable things, if you feel and you can tell that it's mobile, that's a good thing. So another good example, which is one of the reasons why when they do the thyroid testing and they look and they want to make sure it's moving about, okay? Because if it's mobile, that's good. If it's fixated and it's not moving, that's not a good sign. Okay, that means that it is now embedded into the neighboring tissue, and now this particular tumor is possibly spreading. Okay, so those are other good characteristics. So this slide goes into table 7-2 that I told you with the nomenclature, okay, all the names of the cancers. So let's go over how we name cancers. Okay, so the name of the cancer, when you first look at the first word, the root word, okay, will always be for the organ or tissue type. Okay, so lipoma, for example, lipe for adipose or lipid fat tissue. OMA, when you see OMA at the end, so you always look at the suffix will tell you if it's going to be benign or malignant. So OMA as a suffix stands for a benign tumor. Okay, so lipoma, benign tumor of the fatty cell or fatty tissue. Carcinoma and sarcoma, these are for malignant tumors. So even though it has OMA inside of it, the entire thing is the suffix. So carcinoma, sarcoma are for malignant tumors. However, they are used for different tissue types. Okay, so carcinoma is used for malignant tumors of epithelial origin. So say for example, we have all heard of basal cell carcinoma. Okay, so basal cell carcinoma, carcinoma of the basal cell epithelium. Sarcoma. Sarcoma is used for malignant tumors of mesenchymal origin. So say for example, bone, mesenchymal origin type things are going to be things of bone, muscle, cartilage, okay, so those types of things. So a very good example is this, osteosarcoma. Okay, you've heard of that. Osteosarcoma, which is a malignancy of the bone, okay, osteo. Now, leukemia. Leukemia is in a class by itself, as we know, that's a malignancy of white blood cells. And there is one exception to the rule here, and you'll see that on your chart when you go home, is lymphoma. So remember how I said to you that cancer spreads through blood and lymphatic channels. So this is what happens. If a person has a primary cancer in the blood or the lymphatic system, you would never want to address that as a benign situation. Okay, so it's always addressed as a malignancy. And so even if the lymphoma is not that complicated, sometimes lymphomas are just one little single lymph node, okay, not a big to-do. However, they still address it or put it in a category as a malignancy because that's how cancer spreads. Okay, so the reason why I'm saying it's an exception to the rule because yes, it ends with OMA, okay, which you would think it would be carcinoma or sarcoma, but for some reason it doesn't have its category, but it is considered a malignancy. Okay, you'll see that on the chart in your book. Okay, so some information. Cancer is the second leading cause of death in the U.S. What's the first leading cause of death in the U.S.? Heart disease or cardiovascular issue. Very good. The rest of this, you can take a look at that at home. Not a big to-do for what I need to know for next week. It's just some stats on cancer and death. Now, this I will point out what's most important here. This particular chart goes over the percentages of cancers that have been diagnosed at the top portion, and the bottom portion is the percentages of cancers that led to deaths. In both categories, I want you to know the top 4 cancers, okay, which I kind of gave you earlier. The top 4 cancers are going to be breast, prostate, lung, and colorectal. So those are the top 4 cancers. Breast, prostate, lung, and colorectal. Okay, so those particular cancers are the top 4 for diagnosis as well as the amount of deaths that occur each year. You don't have to memorize the percentages. They're there just to show you obviously the top 4, but just make sure you know those. Okay. We all know that cancer does not have a particular known cause. Okay, we wish we knew the cause, but we do not. However, there are a number of risk factors for cancer. And so we'll go over some of the risk factors. So some of the risk factors, we know tobacco use. Okay, so we're going to go into detail with that in a second. Nutrition, there are some nutritional things that people eat too much of that they say can be a risk factor. Obesity can contribute. Sun exposure, we know for skin cancer, and sexual exposure to HPV for cervical cancer, but I want to add to this. I think we have all heard of that HPV has now also been linked, well, I shouldn't say just recently, but it's also linked to men with oral cancer, So just understand that HPV when there are more incidents of cervical cancer with it, however, men also do develop HPV and can lead to oral cancer. Okay. Tobacco use. Now, I love the new smoking commercial they have out. I don't know if you guys seen it with kids with the vapes. Yes. And not the candy too. Okay. Now, the issue is this. The tobacco companies have to inform you, and that's why they have these smoking commercials and try to scare you half to death. Okay? And they need to do that because they have to make you aware that tobacco use can cause a lot of damage, and there is a known fact that it can lead to cancer. This is not a myth, it's a known fact. So we're going to go over the carcinogens in a little bit. However, it doesn't matter because there's still $1 billion industry. So, but they do have to show you and inform you with this. Now, when we say tobacco use, and that's the reason why I like that new commercial out, because you have maybe a younger generation that may not think, okay, well the vape, that's just something else. Okay. Understand, and I think we all know this, tobacco use can be not only cigarettes, this is also vapes, this is also chewing tobacco, also hookah, I don't know what else is out there, okay, with tobacco. So, just keep in mind, any tobacco use can lead to cancer. When we think of tobacco use, we think of leading to lung cancer. Yes, that's usually the top cancer for it. However, please highlight this last sentence because tobacco use has also been linked to these other cancers as well. Pancreatic, kidney, bladder, mouth, esophageal, and cervical cancer. Here are some more stats about lung cancer. You can take a look at that at home, not a big to-do. So let's go into the two types of carcinogens. And again, this is a known fact. Cigarette smoke, or I should say tobacco, has two known carcinogens. One is the initiator that causes the genetic damage, which means it actually will cause that altered gene expression. So it causes an altered gene expression. Once that altered gene expression occurs, then the next carcinogen is the promoter. It promotes tumor growth. So now here we go, we have that abnormal cell. Now let's make it grow. So unfortunately, tobacco is known to have both of these carcinogens. They know this. This is why you will always see smoking campaigns to stop. Okay. And it's so funny how I was talking with someone, you know, the big thing about legalizing marijuana. And this really should be banned, as far as I'm concerned, because it leads to cancer. The amount of cancer cases from cigarette smoke is a lot. It's really a lot. Okay. Now, another thing too is secondhand smoke. Okay, so do not forget that secondhand smoke is just as bad. Okay, one of the students a couple of terms ago, she did a presentation on her grandmother about lung cancer. Her grandmother never touched a cigarette, but she was married to her husband for over 30 years or more. He smoked, she never smoked, she died of lung cancer, he did not. So keep in mind it's just as bad. They still hold the same carcinogens, okay, when you inhale secondhand. Okay, so here are some stats. These are kind of older, maybe changed, but you can take a look at that at home, not what to do. Now, nutrition. There are certain dietary things